Okay, so I'm Shan on the respiratory and ICU training. It's going to update about the 2023 new BTS Pleural Diseases Guideline. So I usually do two teaching sessions about this pleural guidelines, one about pneumothorax and one about pleural effusion. I will try to see whether I can finish this both guidelines in one 45-minute session. So before we start, a little bit of background. The last BTS pleural guideline was published in 2023. Before that, the last guideline was in 2010, and for the last 15 years, we have been following the same guideline, which came in different exams, and it was followed worldwide. So outline for today's talk was about spontaneous pneumothorax, similar to pleural effusion, pleural infection, and malignancy. First of all, I will start with management of spontaneous pneumothorax. So a little bit of question. So a 25-year-old male, tall and thin, sudden onset of shortness of breath and chest pain with oxygen saturation of 96% on the air with this chest X-ray. What will you do? So one of them has said needle decompression. Any other thoughts? Okay. Any other thoughts? So actually, Manpreet wants to measure the pneumothorax size. So this was the guideline that we used for last 15 years. And I remember when I was a very junior trainee as a ST3 in catering, I'd have called in the ED saying there's a 2 centimeter pneumothorax, and I will go down and I will say, this is not 2 centimeters, this is 1.9 centimeters. And the poor patient who is asymptomatic completely will be looking at me and looking at the ED registrar and will be thinking what to do. So this was the guideline previously that we had followed, which came in the MRCP Part 1 and MRCP Part 2 written exams about this 2 centimeter, less than 2 centimeter, all these things. But in the last 15 years, there has been a lot of studies which showed that not all the pneumothorax above 2 centimeter needs any intervention. So there were lots of studies, some of them were published in New England Journal of Medicine about the conservative management of the spontaneous pneumothorax. And the outcome for conservative management of the spontaneous pneumothorax was equally as good as interventional management of the spontaneous pneumothorax, if that meets the criteria. And even in the last guideline, in the bottom of the guideline, it says some of the patients with large pneumothorax, but minimal symptoms, conservative management may be appropriate. But we blindly followed this 2 centimeter and more than 2 centimeter guideline for the last 15 years. So with all this problem, the BTS has updated the new guideline, which came in 2023, and the major changes in the management of the pneumothorax. In terms of spontaneous pneumothorax, the size of pneumothorax is no longer an indication for invasive management. Use of chest drain is mainly centered around patients with high-risk characteristics. I will go through the high-risk characteristics and a more personalized approach and greater patient choice with this new guideline. Conservative care versus ambulatory care versus inpatient management, which can be needle aspiration, chest drain insertion, or the thoracic surgery. So going through the new guideline, so this is the new guideline that was published in BTS 2023. Well, it's not new anymore. It's almost 3 years this guideline has been present here. So previously, this 2 centimeter, less than 2 centimeter has been obsolete, and now it's all patient-centered. So the question is whether patient is symptomatic or patient is not symptomatic. So if you look in the left side of the chart, if the patient is symptomatic, if the answer is no, then we have to go ahead with this conservative management. Now, if the patient is not symptomatic and we are going ahead with this conservative management, if we go through this conservative management, it says regular review as outpatient every 2 to 4 days. Now, if we think about in our region, if we are working in hospital, so who is going to review this patient in 2 to 4 days? So to follow this guideline, you need a very robust ambulatory care service that you can follow this guideline. So I'm not sure about the Northampton, but I don't think Northampton has a very good, robust pleural clinic follow-up. But Kettering and Glenfield, they do have a regular outpatient follow-up clinic. So any patients in Kettering ED or any patients in Glenfield CDU, if you see a patient with spontaneous pneumothorax, you can follow this guideline. But patient has to have proper safety netting regarding what symptoms you should look for and when to come back to the hospital. So going through this new guideline, if this patient is not symptomatic, you discharge this patient with appropriate advice, with a follow-up plan in every 2 to 4 days in an ambulatory pleural clinic, with some advice. I will tell you the advice at the end of the pneumothorax session, what advice you need to give in terms of patient don't be able to smoke, they can't fly, they can't do scuba diving and all this sort of thing. And then this patient will need follow-up in the OPD every 2 to 4 weeks. If the patient is symptomatic or if the patient has high-risk characteristics, which is hemodynamic compromise, significant hypoxia, bilateral pneumothorax, underlying lung disease, most commonly it's a COPD or interstitial lung disease, or more than 50 years of age, living alone, or vulnerable adults, then we have to follow this right side of the pathway, which is whether it is safe to intervene. So it's always important to remember, obviously you need to know how to do the procedure, but it's more important to know when not to do the procedure. So when looking for the pleural procedure, the GIM has made it mandatory for all the medical registrar to get sign off and will be able to do the chest drain independently in the acute day. So it's a mandatory requirement for the GIM curriculum to get signed off. So you need to know when it is safe to intervene. So we call it when it is safe to intervene when there is around 2 centimeter pneumothorax in the lateral valve or in the apical valve. There will be some pneumothorax where the lateral valve will be tethered in the bottom. Those patients probably will not be safe to intervene. In that case, you probably will need some more imaging like CT thorax, or you might need interventional radiology help to drain that pneumothorax if it's need draining. So if it's safe to intervene, then we go ahead with the chest drain, regular inpatient follow-up, remove the drain when resolved, and discharge with a review in OPD follow-up clinic every 2 weeks. So assume the patient had the chest drain, pneumothorax is resolved, and when we discharge this patient, giving some appropriate advice, and the patient will be followed up in a pleural clinic after 2 weeks with a chest X-ray. And if the pneumothorax has completely resolved, then the pleural physician will give some more advice regarding how to follow up that patient. If the patient is not safe to intervene, then we need CT imaging and reassess. Now, if we look at this, if the patient doesn't have any high-risk characteristics, then we can manage this patient in 3 different ways. Whether this is safe to intervene, if no, then conservative management. If it's safe to intervene, then we speak to the patient regarding what is his priority, whether the procedure avoidance, symptom of relief quickly, or symptom of relief in the short-term drainage. So procedure avoidance, again, conservative care. If you want rapid symptom relief, you can do either needle aspiration or chest drain. So there are a few researches going on in Glenfield regarding looking at which is the best option, whether needle aspiration or the chest drain. Realistically, if there's a big pneumothorax, probably around 1.5 or 2 liters air is inside, most of the registrars are lazy like me, and no one is going to do like needle aspiration and remove air 50 ml every couple of minutes. So more frequently, patient is having a chest drain and followed up in the inpatient, followed by in the outpatient. There are some ambulatory devices, but they are not available all the time in all the hospitals. I will come through the ambulatory devices. Those ambulatory devices we can use in those patients. And if the patient is not symptomatic, we can discharge those patients with a regular follow-up in 2 to 3 days' time. So comparing the new guideline with the previous guideline, this guideline is more patient-centered and it's all symptomatic treatment. If the patient is symptomatic, when I say symptomatic, is the patient hypoxic? Most of the time, there is 2 varieties of patient. One are lean and thin. They will say that they don't smoke, and usually they are very young. They comes with the large pneumothorax. On further questioning, you will find out they smoke cigarette, and most of the time it's weed. So weed is the main culprit for this big spontaneous pneumothorax. And the other group of the patient are the COPD patients who are very hypoxic, and you get lots of gula with pneumothorax. So this is the initial management in the acute setting for pneumothorax. If the patient is symptomatic, either you do chest drain or needle aspiration, or you can do ambulatory devices if it's available with the regular follow-up. So the ambulatory devices, there are two types of ambulatory devices available in the South East Midland region. One is this pleural vent. These are one-way valve that you can insert. And if the patient feel like the symptoms has improved, you can discharge this patient with the regular 2 to 4 days follow-up in the ambulatory clinic with some appropriate advices. And there is another set of ambulatory device, which is pneumostat valve. I have not seen this device in this South Midland region. Most of the devices used in this region is pleural vent. It is available in Kettering. Most of the time it is available in Glenfield, but not all the time. So going back to the recommendation, so we have gone through this whole guideline, the pneumothorax, it's all patient-centered. If the patient is symptomatic, we do something. If the patient is not symptomatic, we discharge this patient with some appropriate advice, and patient should be followed up in 2 to 4 days time in the clinic. In the clinic, we will assess the situation, and again, they will have a plan regarding how to follow up this patient. So if the patient is symptomatic and we have done the chest drain, patient has been admitted in the ward, still after 4 or 5 days, patient is still having pneumothorax. What do we do in that situation? Suction, very good. Anything? Any other thoughts? So patient's chest drain is patent. This good, good. So there are two options. One is surgical and one is medical. So to understand what is pleural disease, the pleura is the parietal. There's 2 layers of pleura, parietal and visceral, and there in between there's a small space. So the idea of pleural disease is we are going to give some foreign object, like in the form of talcum powder, sterile talcum powder, so that it is works as an irritant and does inflammation and stings both the parietal and visceral pleura. So though there is no space, if there is no space, there will be no space for accumulation of the effusion or accumulation of the air. And the problem with this pleural disease, medical pleural disease, the success rate is around 60 to 75%. So around 1/3 of the cases, there will be failure, and it's extremely painful. It is extremely painful. So most of the cases, after 4 or 5 days, when the patient has a chest drain and the pneumothorax is still persistent, we usually tend to refer the patient to the thoracic surgeons. The first thing they will say, insert a bigger drain. The second thing they will say, put some suction. If it doesn't work, then they will assess the patient for surgical option. As I said, there's 2 cohorts of this pneumothorax patient. One is the COPD patient. COPD is interstitial fibrosis, who are very lean and thin, and they are not very good surgical candidates. In those cases, if they think that patient is not a surgical candidate, they will have this medical pleural disease in the form of talcum powder or blood pleural disease. Or if the patient is fit and well, they can have surgical options in a form of either VATS procedure or pleurectomy. So this is the new guideline for the BTS 2023 pleural. So the recommendation is conservative management can be considered for the treatment of minimally symptomatic with no significant pain or breathlessness and no physiological compromise, or asymptomatic, regardless of the size. Ambulatory management should be considered for the initial treatment of primary spontaneous pneumothorax in adults with good support. So if you have a good local robust ambulatory clinic in your center, you can refer the patient for the ambulatory service. Otherwise, you have to treat the patient if there is no good support in the locality. In patients not deemed suitable for conservative or ambulatory management, needle aspiration or chest drain insertion should be considered for the initial treatment. Other thing is, if you have treated a patient, discharged home, 6 months later, patient comes back again with a pneumothorax, what do you do?
surgeons?
So there's two options again. So if it's a ipsilateral second pneumothorax, then you refer the patient to the surgeons. If it's a contralateral first pneumothorax, you refer the patient to the surgeons. So most of the cases, surgeon will be saying patient is not fit for surgery. In case patient has advanced COPD or interstitial lung disease, in that case, you have to go through that medical pleural disease pathway. Okay. So, and other thing is you can do surgical, you can refer to the surgeons if patient is in high risk occupations. When I say high risk occupations, pilots, scuba diver, or military personnel. So you can refer those patients for surgical options, even if they present with the first pneumothorax. Okay. So this is a new guidelines for the pneumothorax. Those who, in terms of follow-up, so when you discharge this patient from the pleural clinic or you have discharged this patient on the ambulatory pathway, you have to advise about the smoking cessation advice. Most of the cases, patient will decline. Flying advice 1 week after complete resolution on a chest X-ray. Even if you see the patient in the pleural clinic, unless the patient had a complete resolution, they won't be able to fly. No scuba diving for the rest of the life until it's surgically corrected. And when you are discharging a patient after treating pneumothorax, you have to advise that the risk of recurrence is around 32% for a single episode, or single episode of primary spontaneous pneumothorax, or around 13 to 39 for secondary spontaneous pneumothorax. Otherwise, the next time when the same patient comes with the pneumothorax, they will keep complaining. And the last one is the thing that I've told, that we usually refer for the surgical options after the second episode of spontaneous pneumothorax on the same side, or first episode on the contralateral side. Those who are preparing for the FFICM exam, pneumothorax is a very commonly tested topic in station 7 for the OSCE, where there's anatomy and physiology. The safety of triangle, it comes invariably. They ask about the safety of triangle, which is the lateral border of pectoralis major, anterior border of latissimus dorsi, the base is with the 5th intercostal space or the 4th intercostal space, and the apex is in the base of the axilla. The other thing that is commonly tested in the FICM exam is this seashore sign or barcode sign. But most of the FFICM questions in the OSCE are radiology heavy in terms of pleural diseases. So now coming back to the first question, 25 years old male, tall and thin, sudden onset of shortness of breath and chest pain, oxygen saturation 96% on the ear. What would you do? It all goes about the patient's symptoms and patient preferences regarding the management of this pneumothorax. So coming back to the pleural effusion now, so management of the unilateral pleural effusion. As a respiratory physician, the most common referral topic is the pleural effusion. All the respiratory registrar will get called for the pleural effusion at least 3 or 4 times in a day when they are carrying the bleed. So if there is a bilateral pleural effusion, we usually advise the patient or the clinician to look for the renal disease, cardiac disease, or albumin and treat the cause, which is diuretics, or treat the hypoalbuminemia. If it's a unilateral pleural effusion, then we have to manage that unilateral pleural effusion. So 2023 BTS guideline has shown the management for the unilateral pleural effusion in this flow chart as well. So first of all, you have to ask about the history, clinical examination, chest X-ray assessment, and thoracic ultrasound to understand what is the cause of this pleural effusion. Is pleural malignancy suspected? If the pleural malignancy is suspected, then whether it is safe to perform the pleural aspiration. If it's not safe to perform the pleural aspiration, we straight ahead go with the CT chest abdo-pelvis for the staging CT if it's a high risk for the pleural malignancy. If it is safe to perform the pleural procedure, we still do a contrast CT scan and go ahead with the pleural aspiration. And we usually send diagnostic sample, 4 samples we usually send in the universal white bottles. First of all, we have to do the pH of the pleural fluid. We have to send the biochemical sample in 1 bottle, which is protein, glucose, LDH. microscopy MCS, another bottle, and 2 samples in the cytology. For the cytology, we have to send 2 samples. The BTS recommends sending at least 25 to 50 ml of cytology sample. If the patient has exposure to asbestos, or if you are suspecting patient might have mesothelioma, it is best not to do any pleural intervention and straight away refer the patient for the thoracoscopy procedure. The reason behind that is the chances of false negative cytology in mesothelioma is very high. The yield of mesothelioma in the pleural fluid through the aspiration, diagnostic aspiration, is very high. That's why we straight ahead go with the medical thoracoscopy if we are suspecting mesothelioma. Other reason is sometimes the mesothelioma patient usually comes with a complete whiteout, but there is very little pleural effusion. It's more of a pleural malignancy, solid tumor. So to do the medical thoracoscopy, you need some pleural fluid. Otherwise, the interventionalist won't be able to access the pleural space. That's why if you are suspecting mesothelioma, straight ahead go with the thoracoscopy. If you're not suspecting pleural malignancy, then we have to do lots of other tests to find out the causes. So you have to find out, do the pleural the diagnostic aspiration, which is same as previous. We sent the four bottles along with the pH. Same for the biochemical, which is protein, glucose, LDH, MCS, cytology. There are some additional tests that we need to do. I will go through this additional test. And we have to do some blood tests, like routine blood tests, full blood count, CRP, renal profile, liver profile, albumin. Because some of the cases, they will refer us the patient who had bilateral pleural effusion with the history of heart failure. One left side is probably more than the right side. It depends on what are the risk factors, whether you want to intervene in those cases. If there is a risk factor for like anemia, loss of weight, then probably it's worth doing the aspiration for the assessment. Those who are preparing for the FICUM exam, the commonly tested fact in one of the hospital stations is they will ask what is the normal pH of the pleural fluid. So normal pH of the pleural fluid is around 7.60 to 7.66. Other commonly tested fact in the FICUM exam is in what situation pleural fluid amylase will be raised. I think everyone answers about pancreatitis, but they're looking for 4 conditions, which is pancreatitis, pancreatic pseudocyst, esophageal rupture or leak, post-esophagectomy, and malignancy. These are the common topics they usually ask in the FICUM exam. Other common topics asked in the FICUM exam is the LICE criteria, the exudative and transudative effusion. I'm not going to go through the exudative transudative effusion in this talk. In terms of finding out the cause of the pleural effusion, if you're not suspecting malignancy, if it's a chylothorax, we send pleural fluid for cholesterol and TG and refer the patient to the dietitian for MCT diet. If it's a hemothorax, we do pleural fluid hematocrit. Now, if it's a suspected malignant pleural effusion, the pleural fluid might look red as well or bloody. How do you know this is hemothorax or this is just a malignant pleural effusion? If we do the pleural fluid hematocrit, and if it's around 50% of the serum hematocrit or more than 50% of the serum hematocrit, it's likely hemothorax. If it's less than 50% of the serum hematocrit, it's unlikely to be hemothorax. Other commonly tested fact is the rheumatoid disease with the glucose and pH we have to send, and the lymphoma. If you're suspecting lymphoma and patient having a pleural fluid, for the diagnostic sample, we have to send the RPML sample. We have to go to the lab, get the bottle for the RPML sample. So this is the usual workup for the pleural effusion that we usually do. Now coming back to the pleural infections. So we often see the pleural infection. Patient will come with a pneumonia, with a parapneumonic effusion, with some septations, which is probably evident in the CT scan, sorry, or in the ultrasound finding. So what is the diagnostic workup for suspected pleural infection? So if you're suspecting pleural infection, you have to do a diagnostic tap. and it's all dependent on the pH. As I said, the normal pleural fluid pH is 7.60 to 7.66. If the pleural fluid pH is more than 7.40, it's unlikely to be an empyema, and it doesn't need an intracoastal chest drain. Just sending the pleural fluid aspiration and treating with antibiotics should treat the cause. If the pleural fluid pH is 7.2 or less than 7.2, it's high likely it's a complex parapneumonic effusion or pleural infection, and you have to insert the chest drain. Now, if the pleural fluid pH is in between 7.21 to 7.39, then it might be an empyema, it might not be an empyema. In that case, we have to rely on the LDH, pleural fluid LDH. If the pleural fluid LDH is more than 900, it's likely to be empyema. If it's less than 900, it's unlikely to be an empyema. Either cases, because you're not going to wait for the LDH to come back, which takes at least 1 day, pleural fluid LDH to come back at least 1 day. If you're suspecting empyema with a pH of 7.21 to 7.4, it's better to put a chest drain in. And the treatment for empyema is chest drain insertion along with a long course of antibiotics, at least 2 weeks. They sometimes need antibiotic for 2 to 6 weeks as well. Now, when I say the pleural fluid pH 7.20, it's likely to be empyema. There are a few conditions which can cause pH to be less than 7.20, but which is not an empyema. One is malignancy. So in a malignant pleural effusion, you can get the pleural fluid pH less than 7.2, but it's not an empyema. Other common fact is the rheumatoid arthritis. Poorly controlled rheumatoid arthritis come with the bilateral pleural effusion or unilateral pleural effusion, and the pH of the pleural fluid might be less than 7.2, but it's not an empyema. So you don't need to put a chest drain with the rheumatoid arthritis, which doesn't have any other features of empyema, with a pleural fluid pH of less than 7.2. Now, coming back to the complex pleural effusion with the infection. So if there's a pleural infection or if there's a evidence of any empyema, we have to calculate the rapid score. The rapid score usually helps us to calculate the mortality and the in-hospital stay, length of the in-hospital stay, which usually encompasses the R stands for the renal, which is urea. A is the age of the patient. P is the pleural fluid pass. I is the infection source, whether it's a community or it's a hospital. And D is the dietary fat, which is serum albumin. So if the rapid score is 0 to 2, it's a low risk of mortality. If it's a 3 to 4, it's a medium risk. If it's a high risk, 5 to 7, then patient has high risk of 30 days mortality in the hospital. So if you're suspecting an empyema, the guidelines suggest to insert chest drain, which is a small bore chest drain. It says 12 to 14 francs, but usually the rocket device comes with 2 sizes, which is available in the Glenfield Hospital and Kettering Hospital, which is 12 and 18. First of all, we usually go, if you're suspecting empyema, it's the fastest coming out, we go straight ahead with the 18 francs. If it's a clear fluid, then you can go with the 12, but if you're suspecting empyema, it's better to put an 18 francs rocket drain. So insert the chest drain and then review the progress within 14 hours. If there's a good progress, then patient is improving. If the pleural fluid has completely gone, then you can remove the chest drain because chest drain is a source of infection and carry on with antibiotics. You can switch the oral antibiotics if it's needed. If the patient has poor prognosis or patient is not improving, then we can do further imaging in terms of ultrasound or the CT scan and ask for the thoracic opinion. If the patient is not suitable for thoracic surgery, then we can think about intrapleural treatment. I will come to the intrapleural treatment. If the patient is suitable for surgical candidate, then we can ask for the surgical therapy, which they can do in the form of VATS or the initial treatment. So if the patient is not a surgical candidate, patient is not improving despite having a chest drain in a patient with the empyema, because there are probably a lot of locules. In that case, we can do intrapleural treatment in the form of fibrinolysis. So there are few recommendations in how to do fibrinolysis. In this region, we can do TPA in the form of altiplase and Dornis, which is usually 12-hourly treatment for 3 subsequent days, along with continuous pleural aspiration and fluid irrigation. The second thing you can do is the normal saline irrigation. So Glenfield Hospital doesn't do the normal saline irrigation. Kettering did their own researches, and they have published the normal saline irrigation, and their outcome in their population was same as the TPA and Dornis. So in case patient has empyema, chest drain has been inserted, but you're not getting all the fluids out, patient is not improving, and there are a lot of locules, septation in the ultrasound imaging, there's 2 options: either go ahead with the surgical review and for surgical intervention in the form of VATS, or do intrapleural intervention, which can be intrapleural fibrinolysis in the form of Dornis and TPA. There was a shortage of altiplase last year in the Glenfield Hospital, and they used urokinase instead of altiplase for the fibrinolysis. So this is how we manage the empyema. Most of the cases will need chest drain along with long IV antibiotics. Most of the cases they will need IV antibiotics for 10 days, antibiotics for at least 14 days. Most of the cases they will need antibiotics for 4 to 6 weeks as well. There are a few images in here just to show what sort of effusion we can see. All the images are taken from the radiopedia. So in terms of ultrasound imaging, this is the diaphragm. If you do the ultrasound with the pointer towards the cranially, this is the diaphragm. This is one of the pleural, and this is the anechoic effusion, which is completely black, which means probably it's straw color fluid. This is also a pleural effusion, which is echoic. It might be pus, it might be blood in there, and this is the diaphragm. This is a complex parapneumonic effusion with lots of septations and locules. This is an empyema. So in this patient, you probably will end up doing a chest drain in one of the biggest locules and assess for the surgical therapy. When the patient is fit for surgical intervention, refer the patient to the surgical team. Most of the cases, they will say patient is not for surgical intervention, and then we end up with doing the medical fibrinolysis, which is in the form of Dornis and TPA for 3 subsequent days, which usually removes all this septation, and it becomes a big effusion, and it comes up all through the chest drain. The problem with that, we are giving altiplase. There's a high risk of bleeding. In the patient who are on high risk of bleeding, if the patient is known to have atrial fibrillation on apixaban. So if there is a recommendation that they can reduce the TPA to half dose, instead of giving 10 milligram BD, you can give 5 milligram BD along with 5 milligram of Dornis. Or you can give normal saline irrigation to relieve this septation. So there are some journals, research papers about the intrapleural use of tissue plasminogen activator and Dornis for the pleural infection. These are the fibrinolytics that we usually use. Dornis, which is very expensive. You can use as a mucolytic as well. And this is the Actilyse, which is basically altiplase, intrapleural altiplase. In the cases where this Actilyse was not available, we used urokinase for the fibrinolysis. The management of the malignant pleural effusion. So if we know the patient has a malignant pleural effusion, there are a few options of managing the malignant pleural effusion. So this is the BTS guideline for managing the pleural effusion. If it's a confirmed malignant pleural effusion, if you're suspecting it will be malignant pleural effusion, first of all, we have to assess whether the patient is likely to benefit from intervention. If the patient is not likely to benefit from intervention, if the patient has poor prognosis, weeks, probably best supportive care is the best option, not doing anything and discharging this patient home or to the hospice. If the patient is likely to benefit from intervention, then we have to assess whether the fluid is amenable for intervention. If it's not amenable for intervention, then watchful wait. If it's amenable for intervention and if the lung is expandable, there is two options. One is therapeutic aspiration and two is IPC. Now, problem with the therapeutic aspiration plus minus talc pleural disease, because it's malignant pleural effusion, no matter how many times you aspirate the pleural fluid, it will reaccumulate. So there's two options. One is doing therapeutic aspiration followed by talc pleural disease or IPC. Now, in these situations, we have to ask, have a honest conversation with the patient regarding what do they want. The problem with the therapeutic aspiration followed by talc pleural disease is the chances of failure is around 30 to 40%. In that case, patient will need an IPC. And in the therapeutic aspiration, patient probably have to stay in the hospital for 7 to 10 days because you're trying to do a chest drain, remove all the fluid out of the chest, and then give talcum powder, sterile talcum powder for the medical pleural disease. The whole procedure will take around 4 to 5 days or 7 days. Most of the patients, they are malignant patients. These last 7 days of their life are very precious. So they don't want to spend the 7 days or 8 days in the hospital. Most of them will prefer the IPC, which can be done in the ambulatory clinic, and patient doesn't need to stay in the hospital. So that is one option, therapeutic aspiration along with talc pleural disease, and the second one is the IPC. So IPC is a small silicon tube, which is like a pigtail tube, which goes inside the patient's chest. Depending on how frequently the malignant pleural effusion accumulates, the discharge goes to the patient's house and then drains the fluid 3 times a week or once a week or once in 2 weeks. You can try doing IPC along with talc pleural disease, but most of the cases you give the patient two options, either therapeutic aspiration followed by talc pleural disease. Problem is there is a chance of failure 30 to 40%. It is extremely painful and patient need to stay in the hospital for 7 to 10 days. If it's successful, there will be no drains hanging in the chest. The second option is the IPC, which is a very small silicon tube, which can be rounded up and can stay below the clothes. So which is, the other people won't be able to see the IPC hanging around. And patient doesn't need to stay in the hospital, which can be done all in the as an outpatient setting. So in terms of talc pleural disease, this is a sterile powder that we use for talc pleural disease. As I said, success rate is around 60 to 75%. It has to be done when the lung is completely dry. After doing the chest drain, when the lung is completely dry, we insert the talc pleural disease and then wait for it to effect. We discharge this patient some of the time, around 1/3 of the time it will be failure, and then in that case, for the malignant pleural effusion, we have to do IPC. This is the IPC, which is an indwelling pleural catheter. It can round up as a pigtail and can have a small dressing, so it is not visible outside. The district nurse usually drains this pleural fluid according to how frequently the patient is accumulating the pleural fluid. The pleural nurses in the UHL is Sarah, Faye, and Manju. If you have any questions, you can ask them. The IMTs who are trying to get sign up for the pleural procedure, there is a secretary called Tracy Dickens. In Tuesday and Wednesday, they have a robust pleural clinic in Glenfield. You have to book the pleural clinic and you can get your signed up for pleural aspiration. So in summary, the 2023 BTS guideline, there's emphasis on the conservative management of the spontaneous pneumothorax. The 2 centimeter, more than 2 centimeter size for the pneumothorax doesn't matter anymore. The yield for pleural fluid cytology depends on the cancer type. We know that if it's a mesothelioma, the yield for the pleural fluid cytology is very low. That's why we refer those patients direct for the thoracoscopy. Pleural infection, think for VATS or intrapleural fibrinolytics. Malignant pleural effusion, patient will need chest drain plus talc or IPC. Any questions? Yeah.
In the new guidelines, there is no distinction feature between primary spontaneous and secondary spontaneous pneumothorax. The management remains the same, isn't it? Was used to be like a size in that sense.
Any other questions?
So yeah, so very quickly, just this is Journal Club all about the CSER trial, which is the inhaled sedation in acute respiratory distress syndrome, and it was an RCT that's been recently published. So yeah, published in 2025 in JAMA, and so ARDS is a common present amongst ICU patients, and it's associated with high mortality rates. Mechanical ventilation is a key management intervention in treating these patients, and so sedation is therefore needed to improve tolerance and synchrony. Often in the early stages of ARDS treatment, patients require deep sedation and neuromuscular blockade to facilitate lung protective ventilation. And inhaled volatile anesthetic agents are emerging as alternatives to commonly used propofol. Seem often been used to reduce sedative demand, and it's, you know, an increase in potentially also some sort of inflammatory benefits as well. So what did the study look at? So it was looking at mechanically ventilated patients with moderate to severe ARDS. So they used that, they had with accepting patients with a PF ratio as greater than 150. So within the Berlin definition of ARDS, that sort of sits as at the kind of severe end of the moderate spectrum, and it also included all severe ARDS patients. It was all patients that were all involved within 24 hours of intubation and ventilation, and they had some exclusions, including pregnancy, risk of malignant hypothermia, and other sort of contraindications related to a volatile anaesthetic. The intervention was inhaled sevoflurane via a seconder device that was placed between the ET tube and the ventilator circuit, and then all kind of expired gas scavenging was as per the manufacturer instructions. And that was being compared against sort of routine intravenous propofol sedation. The main outcomes they looked at was the primary outcome was a live ventilator-free days at 28 days, and then their secondary outcomes were 90-day survival and then mortality at both 7, 14, 28 days, and then hospital mortality at 28 days. So from this sort of side, I think, you know, yes, it is a valid study design for an RCT and does address a well sort of set out research question from how they went about doing it. So the patients were randomised. They were randomised early within sort of the first day of ICU stay, and generally were sort of were recruited within sort of 24 hours of sort of the time being intubated and ventilated. They were randomly assigned by the local investigators using a sort of electronic system, and it was a 1-to-1 allocation between the default propofol sedation and then the kind of intervention of the sevoflurane. And then the randomizations were also adjusted based on the hospital site and then ARDS severity, whether or not the patient had an underlying diagnosis of COVID-19 as their cause of ARDS, and also the presence of any hemodynamic shock. So as the participants were recruited, they recruited 700 patients, and that was from about just over 2,000 patients that they screened. The major sort of reasons for patients sort of being excluded was that their PF ratio wasn't sort of severe enough, so that ARDS wasn't sort of at that sort of top half of the moderate to severe spectrum, or that they had their diagnosis for ARDS was longer than that initial 24-hour period. And so of those then 700 patients, those were randomised between the intravenous propofol and the sevoflurane, and of those sort of 700, the vast majority of those made it to the end. Although there was quite a lot of numbers that were lost due to patients that deviated from the study's protocol design. I think it was around about 100 or so from each group, and a little bit more from the sevoflurane group. So I think 267 from the propofol group and 224 that went through from the sevoflurane group. The study didn't stop early. The kind of the blinded interim analysis at sort of halfway through recommended the continuation. So again, the study design seemed good and accounted for sort of for the patients, although there was a few that were sort of lost due to deviations from the protocol. So the data assessors at the end were blinded, but obviously the local investigators were unable to be blinded. It's difficult to work out whether somebody's not got a syringe of propofol or how they were being sedated, and that could be a cause for bias, whether or not people were adjusting how they were treating patients based on what they knew they were being sedated with. However, across the two different study groups, the demographic characteristics were very similar between the group, with sort of very minimal differences in age, sex, comorbidities, their underlying cause of the ARDS, and also the severity. So they had a pretty strict study protocol in order to minimise any deviation from treating patients with either sedation for propofol or sevoflurane. So as part of their study protocol, for the first 48 hours, they had deep sedation that they defined as a RASS of -5 to -4, and alongside that, they were treated with a neuromuscular blockade, and then after that 48-hour period, or if their PF ratio was greater than 150 or their FI2 with an FI2 of less than 0.6, they moved to light sedation, which they defined as a RASS of 1 to 0 with daily awakenings and spontaneous breathing trials. Despite this, the median days of neuromuscular blocking drug use was 5 days. So that sort of suggests that there was a range of quite a number of patients that were deviating from this ideal study protocol, quite possibly due to the fact that this was the sort of data was being collected between sort of May 2020 and October 23. They had a very high proportion of patients with their ARDS as underlying COVID. So obviously those patients tend to be pretty sick for a longer period of time. So hence why the use of the sort of deep sedation with neuromuscular blockade probably extended beyond their sort of ideal study protocol. Other standards of care, including low tidal volume, high PEEP ventilation with a median PEEP of 10 in both groups. There was the major differences that was recorded between the two groups was that the sevoflurane group needed greater numbers of additional sedation on top of that one agent. So 148 patients in the sevoflurane group required additional sedation, as opposed to just 64 within the propofol group. But then they didn't collect data on other interventions, such as whether they had any analgesia prescribed, so whether they had some morphine, remifentanil, alfentanil prescribed alongside that, or what fluids they were given, which may make a difference to the sort of ventilator days and the sort of mortality, which are their primary and secondary endpoints. So what were the results for the primary endpoint, which is the ventilator-free days at day 28? That's the median values was for both groups was 0. but for the sevoflurane group with the interquartile ranges had a much significantly reduced, fewer number of ventilator-free days, i.e. the patient sedated with propofol got off their ventilator a bit earlier. And then in terms of the secondary endpoints, again, across all of the various different endpoints, the propofol sedated group tended to do slightly better. So they had more ICU-free days, and then their mortality at 7, 28, and 90 days was all slightly reduced. They had a large sample size of 687 patients, which was, and it was appropriately powered. The power calculation had been based off estimated 28-day mortality of approximately 35% for ARDS, and so enrolling that sort of 700 patients would give them a decent chance of spotting a variation between the ventilator-free days between the groups. The confidence intervals were pretty narrow, and appropriate statistical tests were carried out based on the data using to compare sort of survival distributions with 2 or more independent groups. They reported any harms or unintended effects, and of which the major one really was that there was a slight higher vasopressor requirement in the sevoflurane group, and also a slightly higher rate of AKI in the sevoflurane group as well. So how would these results help us locally? So this was a study that was carried out in France, so very sort of comparable populations with similar demographics and sort of high income healthcare setting. And I think that they've measured quite relevant outcomes. Ventilator-free days and mortality in days in ICU were quite. They're sort of they are outcomes that are important and matter for us, basically, rather than anything else. But what they didn't measure was any outcomes on sort of delirium or any sort of functional outcomes following their sort of survival from ICU, and that might have been quite nice to know as well. The study was done alongside a study protocol that sort of fits current ICU ARDS management that we would typically do in terms of sort of sedation, sort of lung protective ventilation, low tidal volumes, high PEEP with a neuromuscular blocker. So it's sort of very reflective of how we would treat patients. And also they were selecting patients that had a sort of moderate to severe ARDS early after intubation, reflecting a high risk ARDS subgroup, which are commonly managed with deep sedation. So any outcomes that this study was to spot would be able to be utilised. So in general, overall, it was a large multi-centre RCT with early enrolment of patients that allowed randomisation to occur for some key outcomes that we wanted to know, and a lot of the endpoints were quite clinically meaningful and important for us, and it had some protocolized the sort of other ARDS interventions that go alongside it in order to sort of minimise any variation. Some of the limitations include that it was the lack of blinding to the local investigators. It gives a potential for some influence on when patients were liberated from the ventilator or discharged from ICU, although it's probably unlikely that patients would be kept on ICU for longer once they were able to be discharged. There was quite a high rate of deviations from the protocol, particularly in that sevoflurane group. Whether or not that was reflective based on some of the patients and their underlying cause of the ARDS in terms of it being COVID-19. They didn't collect data on some interventions that they did, such as so if they were co-prescribed any analgesic agents or what they were doing in terms of their fluid management and fluid balance. And again, mention again, a high portion of these patients had COVID-19 associated ARDS as their underlying pathology. And so how reflective it is to a wider subgroup of patients would need to be questioned. But overall, I think that this was, a well-designed RCT that is relevant to our practice here, and therefore the results should be sort of utilised and sort of in terms of how we sedate patients with ARDS. Well, so in summary, in moderate to severe ARDS, inhaled sevoflurane sedation was associated with fewer ventilator-free days and a higher 90-day mortality than sedation with intravenous propofol. And so therefore, sort of the hope that volatile anaesthetics and sedation with sevoflurane, for example, could sort of prove an alternative suggests that maybe actually what we're doing at the moment, sort of primarily with propofol sedation, is actually the thing to continue with and continue doing. If anybody's got any comments that they'd like to add in or questions, I'll try and answer them.
Thank you, Tom. Are you guys using sedation much? Like Phantom?
Bit of the echo. They usually get to sedation a bit. It comes out occasionally. I think I wouldn't stretch as far as a lot.
Yeah, same.
I only used it for about 2 cases in the last 6 months.
I used it 2 weeks ago for a patient I couldn't sedate properly with any other IV stuff, and it worked really well.
It's been a few where it's like it's been the solution to escalating difficult sedation. We go up to that and then sort of use it as a way out. It's helped in this, but it's not. I don't think we haven't used it as like primary sedation for staff.
Yeah. The other question I had, I just a lot of these the recruitment was during COVID, wasn't it? So that they were sicker for longer. We haven't used muscle relaxants for difficult to ventilate patients, but in COVID probably actually we don't do it very often. Do they do it with any of the staff patients over there very much? We try and avoid it.
So it gets that bad more often here. Most some patients do but
yeah. Plenty of you been and picked up that all you have.
Yeah, and we strongly insist on the
part two. Yeah, but we don't see it.
Yeah, we don't get it ourselves in the centre because it's not the general pathway by which this actually experiences.
I mean, what percentage of patients were COVID?
It was I think it was about 60% or something. So it was pretty. It was the vast. It was a majority as opposed because it was they were recruited patients basically between May 2020 to October 23. So it was kind of across all waves of COVID really.
COVID was a thing, I was going to say. Generalisable.
I mean, it's got a lot of common features, but it was this constellation was quite distinct. I think with the Sedaconda though, for us, I found it really useful. And it made me consider using it instead of isolation.
Yeah, 10 minutes. So I think it's about. Otherwise, I can talk to them.
I don't know, Jack, my function.
Thanks, guys. I shared the feedback in Give feedback for Shannon, Tom.